All right, today we're going to be studying one of the exemplars for glucose regulation, and that's diabetes type 2. So grab your notes, grab your textbook, and let's study along together today. So diabetes mellitus is a group of disorders that's characterized by elevated blood sugar levels in the body. And that elevated blood sugar is either caused by the body not making enough insulin or the body not responding to insulin appropriately, or sometimes a little bit of both. Today we're talking about diabetes type 2, which means that the body does not respond to insulin appropriately. There's a defect in the insulin action in the body. So let's just dive again into the pathophysiology of glucose regulation. Remember, like everything, our body wants homeostasis, normal glucose regulation, just like Goldilocks, not too much, not too little, just the right amount of blood glucose. And so it regulates that through a couple of organs in our body and a couple of hormones. So if our blood sugar is high, the pancreas, the beta cells in the pancreas are going to be stimulated to create insulin. Insulin is a hormone that unlocks the cells and lets glucose in. So all of that circulating blood sugar that's just in the bloodstream can then enter the cells, and then the cells can use them. The cells can either use them right away for energy, or it can be stored for energy later. Now, if the body has low blood sugar, on the other hand, then the pancreas is stimulated to release glucagon. So glucagon is the opposite of insulin. Insulin lowers blood sugar. Glucagon raises blood sugar. So glucagon is created by the pancreas to tell the liver to break down glycogen, stored sugar, and release it as glucose into the body. And so between insulin telling the body to lower blood sugar and glucagon telling the body to raise blood sugar, we're able to have homeostasis, normal glucose regulation. And when we have disorders in this, that's how we get diabetes. And unfortunately, in our country, there is a huge prevalence for diabetes type 2. In fact, 9.4% of our population had diabetes in the United States. And diabetes type 2 accounts for about 90 to 95% of those cases, with diabetes type 1 accounting for only 5 to 10%. We're going to touch on diabetes type 1 in class, but we're really going to cover it more in the spring. Diabetes type 2 is a lifestyle caused disorder. And so as you get older and you've had maybe unhealthy lifestyle choices along the way, we get more likely to have diabetes type 2. So it's more common in adults than juveniles, although with the standard American diet and decreased activity in our country, we're starting to see kids as young as 8 or 10 getting diagnosed with diabetes type 2. It used to be called adult onset diabetes, and it no longer is. So again, it really is lifestyle dependent for diabetes type 2. So the risk factors are going to include obesity, lack of physical activity, cholesterol. Cholesterol and diabetes, the science is still out on which came first. It's kind of like the chicken or the egg. Does high cholesterol cause high diabetes, or does diabetes cause cholesterol? There's controversy there, but we know that they're related. Metabolic syndrome is another risk factor. Metabolic syndrome is characterized by a lot of fat accumulation around the abdomen, so a large abdomen, along with high blood pressure, high cholesterol, and high blood sugar. So these metabolic syndromes kind of go together. If you've got high blood sugar, high blood pressure, fat around the abdomen, those are all risk factors as well. And there is a social determinants of health issue here, as Black and brown patients are at higher risk to get diabetes type 2 than white patients. And it has to do a lot, not necessarily just with genetics, but also with those social determinants of health. Access to good health care, access to healthy food, access to physical activity. It's definitely one of those social justice issues as well. So now that we've talked a little bit about the pathophysiology of glucose regulation and how insulin is the key that unlocks cells to let sugar in, and we've talked about some of those risk factors, now we can kind of understand how diabetes type 2 works. So over time, patients who have diet and lack of poor diet and lack of exercise, and are just constantly bombarding their body with lots of glucose and no exercise that kind of helps deal with that, their pancreas has to create lots and lots of insulin, because the more your blood sugar goes up, the more your pancreas makes insulin to accommodate for that, so that you have enough keys floating around in your bloodstream to unlock those cells and let all of that glucose in. But over time, the cells get so overwhelmed by all this insulin and by all these keys that it's just kind of like, I can't pay attention to you anymore. I'm so overwhelmed by this insulin that it stops paying attention. And so there's more insulin required because the blood sugar is constantly high. And over time, the cells become resistant to that insulin. They stop paying attention to it. So there's insulin floating around, but the cells aren't listening to it. And then, because the glucose is still high in the bloodstream, eventually the pancreas just, has to keep producing more and more insulin, and the pancreatic cells die because they just get so tired and kind of worn out from being this insulin factory. So ultimately, patients with diabetes type 2, while they don't usually need insulin at first, ultimately their pancreas kind of wears out. And so chronic diabetes type 2 patients often also require insulin. So as we think about the signs and symptoms of diabetes type 2, I want you to remember the 3 polys: polyuria, polydipsia, and polyphagia. So one way our body is able to get rid of excess glucose is through urination. And so polyuria, the body just starts voiding a lot frequently and a lot of it to try to get rid of the glucose. But if we're voiding a lot and frequently, we're going to get dehydrated. And so we're going to be really thirsty. Polydipsia means extreme thirst. So we have lots of urination, lots of thirst. And polyphagia means you're really hungry. And that's because the blood sugar is not actually getting into the cells. And so while you have all this blood glucose floating around in your bloodstream, the cells are still deprived of nutrients. And so it's telling your body that you need to consume more food. So those 3 polys are really key for recognizing high blood sugar, hyperglycemia. And then the other thing you need to think about is when you have all of this blood sugar floating around in your vascular system, think about the blood being like molasses or like maple syrup. It's thick, it's sluggish, and so it doesn't perfuse well. So diabetic patients have problems with perfusion because they've got this thick molasses syrupy blood sugar or blood floating around their body. And so because of that, they can have poor wound healing due to poor perfusion. They can have cardiovascular disease due to poor perfusion, as well as the elevated cholesterol that goes hand in hand with diabetes. We can see diabetic visual disturbances. Things like glaucoma, cataracts, and diabetic retinopathy are all complications from diabetes type 2, as the eye itself does not get good perfusion. We can see renal insufficiency, poor kidney function due to lack of good perfusion. And then because we don't have good perfusion, we can see a risk of recurring infections as well. So all of these signs and symptoms have to do with the body handling the excess glucose or having problems with perfusion and cholesterol issues. Now here are some blood sugar lab tests that we can perform to assess someone for diabetes or to see how their diabetes is doing. A hemoglobin A1C actually gives you a snapshot of kind of how the patient has been controlled with their blood sugar over the last 3 months. It gives you more of a long picture of compliance and how the patient's doing. So a patient without diabetes is going to have a hemoglobin A1C of less than 5.7. Pre-diabetes is going to be 5.7 to 6.4, and a diabetic will have a hemoglobin A1C of 6.4, of higher than 6.4. Now, for someone who already has diabetes, as long as their hemoglobin A1C is less than 7, that shows pretty good glucose control over time. Now, these other 3 tests on here show a snapshot. It just tells you right now what their blood sugar is. So a fasting blood glucose means that they haven't eaten in the last 8 hours. And someone who is healthy and non-diabetic will have a fasting blood glucose of less than 100. Pre-diabetic, 100 to 125, and diabetics will have a fasting blood glucose of greater than 125. Now, if someone has eaten, after they eat a meal, 2 to 3 hours after eating, their blood sugar should go back to normal. Our body should be able to handle the bolus of glucose from our meal. And so a normal person without diabetes will have a blood glucose of 120 to 140, 2 to 3 hours after eating. And then prediabetes will be 140 to 160, and a diabetic would show a postprandial blood level of 200 or higher. Now, anyone having a random blood glucose, fasting, not fasting, anything, it doesn't matter, at any time should never be higher than 200. So regardless of whether they ate, if you see a blood sugar higher than 200 at any time, that's definitely a warning sign. So once someone has diabetes, what do we do about it? Well, we educate, educate, educate. Remember, this is a lifestyle-driven disease. And so exercise and good nutrition can really help with the patient managing this. Not only that, but they need to monitor their blood sugars regularly and record them. We want to teach them how to eat appropriately, to monitor their blood sugar levels, to exercise regularly, because exercise actually helps glucose enter the cells, just kind of like insulin does. And it increases the sensitivity to insulin from the cells. And then, of course, we want to monitor for those complications, cardiovascular complications, vision changes, renal failure, wound healing, all of those complications that can go along with diabetes. Now, there are a variety of medications that we talk about when we talk about managing diabetes, and we're going to talk about these more in class, but there are a couple different categories to think about. There's oral anti-diabetic medications that help drive down blood glucose levels, and those oral medications are only going to be for type 2 diabetics. We'll talk about that in class. And then there's insulin, and insulin can be used for diabetes type 1 or advanced diabetes type 2 if the type 2 diabetic's pancreas is starting to wear out and be tired. But remember, the side effect of these is hypoglycemia. Just like when we give a hypertension medicine, the risk is that the patient goes hypotensive, right? That we overdo it. And so the risk with these medications is that we overdo it and that they end up hypoglycemic. So complications of diabetes type 2, as we talked about, really have to do with prolonged high blood sugar that causes problems with the cardiovascular system and with the metabolic system. And so patients with diabetes type 2 are at increased risk for infection or poor wound healing. We'll see patients with really bad diabetic foot ulcers that won't heal. We'll see patients with prolonged hyperglycemia over time, just that thick, syrupy blood floating around in their body. Vascular, cardiovascular, and renal effects. Vision issues like diabetic retinopathy, which is causes blindness. Diabetic peripheral neuropathy, meaning numbness and tingling, especially in the feet, having to do with poor perfusion and the nerves dying off because of that. And then in extreme cases, we can get some really bad metabolic disorders like HHS or DKA, and we'll be talking about those more in 119. As always, let's review the nursing process as it pertains to diabetes type 2. The first thing we always do is assess. So what are we going to notice if someone is having maybe new onset diabetes type 2 or uncontrolled diabetes type 2? Well, we're going to notice signs and symptoms of hyperglycemia. And so you remember those from your concept study guide. Those 3 polys are some of the key factors: polydipsia, polyuria, and polyphagia. But we can also see signs and symptoms of complications from those long-term effects, such as blindness or seeing spots in their vision, tingling or lack of sensation in the extremities, poor wound healing, poor kidney function, renal function tests would be off, and even cardiovascular disease, things like hypertension, strokes, heart attacks. These are the kinds of things we see with long-term poor control of glucose regulation. Some nursing diagnoses related to diabetes type 2 are risks for ineffective tissue perfusion, ineffective renal perfusion, or risk for infection. As always, your Davis text talks about the interventions being what assessments to make once you know someone has diabetes type 2, what actions to take, and what teaching to do. So in terms of assessments for someone with diabetes, of course, we're going to monitor their vital signs. We're going to check their blood sugar level. We're going to ask them about self-management. Are they able to take their insulin on their own? Are they checking their glucose at home? Do they know how to use their equipment? Do they know how to manage their diet? We're going to ask if they're on insulin or oral glucose control. A very small amount of patients can be managed just with diet and exercise alone. We're going to check their cap refill time because these patients have perfusion issues. We're going to do a good skin assessment. Because of the peripheral neuropathy, the lack of nerve sensation, especially in the feet, patients can have skin wounds that are going to have really hard time healing and that they might not even feel. So we need to do a good skin assessment to look for any wounds. We want to monitor their intake and output. Remember polydipsia, polyuria, polyphagia, so we can see increased urination, increased thirst if someone is hyperglycemic. And these patients are at risk for renal failure, so monitoring input and outtake is going to be helpful for that. In terms of lab tests, anything to have to do with cardiovascular assessments, things like cholesterol levels would be really helpful, as well as kidney function, hemoglobin A1C, or blood glucose level at the bedside. Now we want to monitor their urine for protein in their urine, microalbuminuria, which means that the kidneys are spilling a very small amount of protein into the urine. And the kidneys should not spill protein in the urine, and it's a strong predictor of diabetic nephropathy, which means renal failure. And so if we see small amounts of protein in the urine, it indicates that the kidneys are not doing well. And then, of course, we want to monitor their carbohydrate intake at meals because carbohydrate intake is going to be directly related to their blood glucose levels, their blood sugar control, and if patients are on insulin, sometimes the amount of carbohydrates they take at a meal will directly relate to how many units of insulin they're going to need. We'll talk about that more in class. Now, in terms of actions to take, we're going to monitor their blood glucose, and we can do that right at the bedside with blood glucose monitoring. You do need an order for that. We're going to administer any diabetic medications, whether it's oral or insulin. We're going to administer isotonic fluids as ordered because in the short term, hyperglycemia can cause dehydration, and isotonic IV fluids like lactated ringers or 0.9 normal saline help to increase fluid volume without causing shifts in the cells. And then because these patients are at risk for infections, if the patient has infections, of course, we're going to administer antibiotics as ordered. Now, in terms of teaching to do, did you know that there's actually jobs for nurses to be diabetic educators, and they literally meet one-on-one with patients all day long, or in small groups and support groups, to teach patients how to maintain their health and manage this chronic condition. Because good management and getting the patient involved at home is really the key to good long-term compliance and better outcomes for the patient. And so we want to teach them about how to manage their medication, how to check their blood sugar levels, and specifically how to use their equipment, how to maintain a healthy lifestyle through nutrition and exercise, what signs to look for if they're hypo or hyperglycemic so that they can notice that and check their sugar and act accordingly. You want to teach them to do good foot care, and we'll talk about that in class, but to prevent any injuries to their feet, because if they get an injury, they can get a really bad wound that they might not even feel, and that has a really hard time healing. And diabetics are at high risk for getting amputations, so we want to make sure that we're teaching them to, keep their feet protected. And then finally, monitoring for those complications, especially things like cardiovascular health. So teaching them signs of strokes, teaching them how to monitor their blood pressure at home, signs of a heart attack, when to go to the hospital for medical care, and making sure that they're following up with their eye doctor, their ophthalmologist regularly to prevent those complications with their vision as well. So how do we know we did a good job with our diabetic patients? Well, we want to see tight glycemic control. We want to see a hemoglobin A1C of less than 7 in our diabetic patients, and that they don't have these huge variances in their blood sugars. You know, that we have pretty good range of tight glycemic control as we look at their sugar levels. And we want to see them avoid those complications. We don't want to see their kidneys fail. We don't want to see them have high blood pressure or have high cholesterol, or the side effects of that, the strokes and heart attacks. We don't want to see any vision issues like diabetic retinopathy or cataracts or glaucoma. So we want to prevent all these complications, wounds, and diabetic foot ulcers. And so we need to teach the patients so that we don't see those complications. So tight glycemic control and not having these complications from diabetes type 2 tell us that we're doing a good job managing those patients. And that's what you need to know for now for diabetes type 2. See you in class.